Let's continue building out the preoperative phase by talking about informed consent and the essential documents a patient needs before they ever go to surgery. This is one of the biggest pieces of patient safety, ethics, and legal protection, and it's also a major part of good communication. Informed consent is more than a patient signing a form. It's an autonomous decision made by someone who actually understands what is about to happen and why. For any non-emergent surgery, consent has to be voluntary, written, and obtained before the patient receives any sedating or psychoactive medication. The purpose is simple: protect the patient from undergoing a procedure they didn't agree to, and protect the surgeon from any claim of unauthorized surgery or battery. It's a legal requirement, but it also prepares the patient mentally. When people understand the procedure, its risks, the benefits, and alternatives, they go into surgery with more confidence and less fear. The explanation itself must come from the surgeon or the anesthesia provider. They're the ones responsible for explaining what the surgery involves, what the benefits are, what the alternatives are, and what the risks and possible complications may be. If there will be cosmetic or functional changes, such as scarring or the possibility of disability, that information has to be included. They also review what to expect during early recovery and what may occur later on. The nurse does not obtain informed consent. The nurse can clarify information the patient didn't catch, confirm that the form is signed, and witness the signature if needed. But if a patient expresses confusion, or if they ask a question the nurse isn't ethically allowed to answer, the nurse must pause, stop the process, and notify the provider. And once again, consent has to be obtained before any sedative is given. A sedated patient cannot legally consent. Certain situations always require written consent, including anything invasive, anything requiring anesthesia or sedation, high-risk non-surgical procedures like arteriography, procedures involving radiation, and the administration of blood products. Patients sign for themselves if they're of legal age and mentally capable. If they are not, then a surrogate decision-maker, usually a legal guardian or next of kin, signs instead. In emergencies, the surgeon may have to operate without formal consent to save a life. Even then, every effort should be made to contact the patient's family, and consent can be obtained by phone, fax, email, or other electronic means. All attempts must be documented, and any signed form must be placed prominently in the chart and sent with the patient to the OR. For informed consent to be valid, a few essential elements must be present. First, the consent has to be voluntary, free of any coercion. The patient must be at least 18 or legally emancipated, and the signature must be witnessed by a professional staff member. Second, the patient has to be competent. A patient is considered legally incompetent if they cannot understand or make decisions because of cognitive impairment, mental illness, or neurologic incapacity. These patients need a legal guardian or a designated surrogate. Third, the patient must be fully informed. The consent must be in writing and include an explanation of the procedure, the risks, the benefits, and the alternatives. Patients must have the chance to ask questions, must be able to withdraw consent at any time, and must be notified if the planned procedure differs from standard practice. The final element is comprehension. If the patient speaks another language or has a sensory disability, the information must be provided in a format they can understand. That may mean using a trained medical interpreter, written materials in another language, Braille or large print documents, or sign language interpretation. Nurses play a key role in ensuring comprehension. One of the best techniques is the teach-back method. Ask the patient, tell me in your own words what surgery you're having and what to expect. If they can explain it back correctly, you know they understand. Patients also have the absolute right to refuse surgery. If a patient expresses hesitation, asks for more time, or wants a second opinion, those requests must be honored. They should never be pressured to sign anything. If they refuse, the nurse documents the refusal, notifies the surgeon, provides any needed explanations, and reschedules when appropriate. There are also special consents that offer additional protection, such as those for sterilization, therapeutic abortion, organ donation, blood product administration, and the disposal of severed body parts. These may vary by state or region. Another essential preoperative requirement is the history and physical. A complete, updated, and signed H&P must be on the chart before the patient goes to the OR. It has to be completed within 30 days of the surgery and then updated within 24 hours of the procedure. This applies to all non-inpatient surgical patients. The H&P includes the history of the present illness, past surgical and medical history, social and family history, allergies, current medications, and the plan of care. It's the responsibility of the surgical team to ensure that all supporting documents, medication reconciliation, power of attorney documents, advance directives, are complete, accurate, and easy to find before the patient goes to surgery.